This week on the BackTable podcast.
It is hard to get second opinions. It is hard to go down this path, but there are a lot of resources to help people. There are actually resources to help fund even transportation for second opinions. A lot of them can be done virtually now. I encourage all the folks that I mentor to just push hard, try, ask questions. No question's a dumb question. Look for mentors. Look for people that can help you that have been through it before, because you're not alone.
Hello and welcome to the BackTable podcast, your source for all things interventional and endovascular. I'm your host, Eric Keller, an interventional radiologist in southeastern North Carolina. I'm also on the board of the Interventional Initiative, a nonprofit devoted to raising awareness of and access to minimally invasive image-guided procedures. So today, actually, rather than chatting with someone about performing one of those procedures, we're instead going to talk to someone who has had not one, but multiple of those procedures, about their experience, with the idea being to raise awareness among the general public about these life-changing options. So today we have Lynn Lazzaro, who is a cancer survivor who has undergone actually numerous interventions for cancer, including, and this is only part of the list, 2 resections, 2 radioembolizations, 4 chemoembolizations, 4 ablations, and all of this and more by her multidisciplinary team at Johns Hopkins. So she was kind enough to come on the show and share her experience with us. So I really appreciate you coming on the show with us, and welcome to BackTable.
Thank you. Thank you. It's a pleasure to be here.
So how about to start, if we go back to the very beginning of this journey. So maybe talking about, that diagnosis, how you first found out about these options, take us back there, and then we can kind of work our way through it.
In January of 2016, so it's a long time ago, after a pretty serious bout of indigestion, my doctors discovered a 13.5 centimeter mass on my liver. And I was missed 2 years earlier when it was only about 8 millimeters, unfortunately. But from the beginning, my IO team was the ones that gave me a very honest assessment of my prognosis. At the time, they thought I had a year to live, maybe 2 with treatment. But here we are, almost 9 years later. I'd say how I found them was luck. Obviously, I had a friend that worked at Hopkins and put me in touch with a surgeon. And because they have this multidisciplinary approach, they were able to talk to each other about the best way to treat me. And so, I know that the running joke with patients is surgeons like to operate and radiologists like to radiate, on and on. But they all put their heads together and talked about the best thing. I think given the size of my mass and the location, surgery was not an option at the time. I was introduced to the IO team at Hopkins, who began with TACE and, went through lots of iterations over time. Initially, I guess the goal was to prolong my life and minimize my symptoms. But eventually it shifted and really was a miracle to extend my life, which was quite a gift to me, but then ultimately really offered me a chance at a cure, which was transplant after downstaging.
Wow. Okay. So you started with the TACE then.
I did.
And just to back up, it's interesting because the theme of the other conversations that we've had so far with patients has been actually different than yours in a negative way, that it's been more of that they weren't told about these options in a multidisciplinary team, and then they had to kind of advocate for themselves. You instead had this multidisciplinary team, and that highlights nicely, as you said, us working together since it's a team sport. But then so you're hooked up with TACE. What's that first procedure like? What was it like undergoing chemoembolization?
I'll answer from a couple of perspectives, Eric. It's a difficult procedure. It's a lot easier than surgery, certainly, but it's something different, something I didn't really understand. So you read a lot about it, and Hopkins has a lot of great materials that kind of coach you through what to expect, but it's never quite enough. So you read, you try to get your mind around it. But as you know, from a patient's perspective, with any of these procedures, you feel pretty vulnerable. You're quite exposed. I mean, literally exposed, right? You're in a backless gown. A stranger shaving your groin.
You're sedated.
You're sedated. Although It's funny, not fully, which is fine. I remember once saying, you guys, I can hear you talking. And they said, well, if you don't, you want to be out? Like, no, I'm fine. Just so you know, I can hear you talking.
So don't say anything you regret.
Yeah, don't say anything strange about me. It's scary. You're in this room with all this equipment. It's very high tech. A lot of people, I would tell you, the staff are great. They try to make you feel as comfortable as possible, but No question. You feel very exposed. But the one thing I'll say is they never treated me like a liver, right? They treated me like a whole
A
person.
person.
Yeah, and treating me like a whole person really gave me the resilience to keep going, and obviously retain some dignity in the whole process of being shaved and vulnerable and all that.
Was there something specific that you feel like that they did? Because I feel like clinicians aren't always good at that, of treating someone not like a liver, but a person.
For me, and it's really the advice, I do some mentoring of other patients now, and I always tell them to be a strong advocate for themselves. And so for me, it was about developing a relationship with them. So I would go in with an agenda. I'd try to, this was pre-COVID, I'd take someone with me as well, because, you always want to have 2 ears listening, not one. And my husband was, at every appointment with me. And so we had 2 people listening, but I went in with an agenda. And so I think they could tell I was clearly engaged. And I used to joke and say that we should retitle sessions like this, How to Deal with a Difficult Patient Like Me. And I was pretty assertive. I was resolute. I was reasonably well informed for a CPA, in terms of the medical stuff. But I always encourage people, be an advocate, engage with, you're not just a doctor either. You're a human being. I'm not a liver. Engage with them in that way. Let them know that you're reading, you're thinking, you have questions, you're following up. Get to know them to the extent you can in a 15 or 20-minute meeting, a little bit on the personal side. And I think so for me, knowing who they were and them knowing who I was helped me a lot, just helped me a lot.
Well, it's humanizing. I mean, this is a human interaction, a very human profession with the vulnerability and everything to connect on that level. And, you're the expert on you. Your IO team might be the expert on IO, but you need both of those inputs to really make that informed, shared decision.
The other thing I'd say is I went in with an agenda all the time. It's funny. I had a friend suggest this to me. I developed as kind of a standard agenda for my meetings that had all my treatments initially, and I built on that as I went. And sometimes that was helpful because, again, the meetings are short. Someone might say, Lynn, how many nivolumab treatments have you had again? Well, my last one was on such and such a date, and I've had 14 treatments. By the way, I think that was a record at Hopkins at the time. But because all this stuff overlaps, as you know, they don't want to do this type of treatment within X number of days of my last nivolumab, and it's hard. So I had, the highlights of all that on a piece of paper, and then I had my questions and my follow-up. But I ended every meeting with the same question, which was I wanted to know what my prognosis was. And I know that's really harder for some physicians than others. But I really think having that honest assessment helped me and my family make better decisions and feel like you're in control a little bit at a time in your life when you're not in control of much. So,
yeah, that's interesting because, kind of like you said, I feel like that's an uncomfortable question for a lot of clinicians, or clinicians say, well, I don't want to say because it's, it's too variable, or they feel there's also this almost paternalistic idea of not wanting to discourage you, of like, if you have 2 months to live, you don't want to say that because there's this almost superstition that that's going to, take the wind out of your sails and
right.
Something else like that. But, to your point, it's kind of being realistic to make this informed decision. And I think that's true of a lot of people. It'd certainly be what I would prefer.
It is hard. I know it's hard for the patient. I know it's hard for some of the physicians, but I would just encourage people to say, and again, with the folks that I mentor, I really encourage them, get a second opinion, get biomarker testing, walk in with an agenda and ask the prognosis. That's kind of my standard formula. And they'll do the first 3 pretty often. They just don't want to ask sometimes. So I just think for me and my family, it really helped us make better decisions. I always tell people I was on a dual path. I was going to either live the best life possible with my diagnosis, or I was going to die the best life possible with my diagnosis. And that might not sound hopeful. It was hopeful, but it meant I had to do certain things. I'm a CPA and I do some podcasts on getting your affairs in order. And again, that doesn't sound hopeful, but frankly, all of us should have our affairs in order, not just when you get a cancer diagnosis. So it really helped me to get focused and focus on getting better, really, as best I could.
Yeah, it sounds more like just being realistic about what's going on to weigh kind of all your options, and regardless of which way it goes, kind of be prepared for that and taking back that control, as you mentioned before. In a way, I'd have to imagine that getting your affairs in orders is also a way of kind of having that sense of control as well over in this sense of uncertainty.
That's right. I always joke and say if I had a gerbil, it would have a trust. In other words, I really started, I got pretty focused, everything was, in fact, even the house got cleaned out. Oh, that's good. It's good to clean your house out. But I got a lot of things straight. But, I know for you guys, it's informed consent, and that means something special to you all. To us, it's just an understanding of people asking me, Lynn, do you understand your diagnosis right now? What are your goals? What are your husband's goals? What are you willing to do for that outcome? It's the humanizing, better understanding part of it that I think really helped me get better, or fight to get better, put it that way. Obviously, the treatments helped me get better.
Well, yeah, let's talk about the treatments then. So you fell exposed, you get this chemoembolization. How was it, I guess, during it afterwards, in terms of, you have a lot of side effects? Take it you went home the same day type thing. What was that like?
Yeah, I was lucky enough to, I think I went home the same day every time except maybe once, and I don't recall why. But yeah, I definitely had classic, high temperatures, fever, spikes, sweats at night, but didn't last long. I mean, it was pretty much exactly what I was told to expect. I was able to deal with it. A couple of the things I did to fight my way back all the time was to be outside. We have a pretty long driveway. I'd get, whether it was winter or the summer, I'd get out there and walk up and down the driveway as best I could. So for me, just fresh air, try to get active, try to eat, try to do, all the basics, and re-engage. So for me, I was working at the time, and I had a small business. In fact, it's funny, I didn't tell anyone. In fact, other than like the privacy of this podcast, almost no one knows about my adventure all these years later. Yeah. So re-engaging kind of helped me. But yeah, the side effects were exactly what you'd expect. The fevers, the chills at night, some nausea. But generally, and it was short. Maybe that lasted a half a day. I handled it all pretty well.
So within 2 or 3 days, you were kind of feeling back to baseline. Okay.
Yeah, I because I had several, I kind of got into a routine where I would try to have it done if I could on a Thursday or a Friday, and I'd be back in the office on Monday.
Okay. And then was it different then between, I guess, the chemoembolization, then you had the radioembolization? And just for people that listening that might not be aware of those two things, they're both putting little beads into the tumor in the liver, but the chemoembolization has chemotherapy in it versus the radioembolization is radiating the tumor from the inside out.
I'd say the only difference was the precautions I had to take with the radioembolization in terms of, bathroom sharing with my husband and hugging small children and, all that. I was nuclear for a couple of days, I guess. But no, beyond that, I think I tolerated them both equally well. The tear might have actually been a little easier in hindsight, but they were reasonably similar.
Okay, that's what, in our literature, it's supposed to have less of that, what we call the post-embolization syndrome, because the beads are smaller. They don't block the blood vessels as much, so people tend to have a little less of that fever, flu-like thing for a few days. So it's interesting.
You're forcing me to go back in memory a long way.
Well, let's keep marching then sooner to today. So, I mean, we've only made it through, a handful of the procedures, but you also had resections, right, and ablations too, which I know resections isn't us, that's our surgery colleagues. But when did, I guess, that happen? So you had the chemoembolizations and then the radioembolization.
So all of the IO treatments were to hopefully get me into the Milan. Well, initially they were to minimize my symptoms and prolong my life, which again was quite a gift, but ultimately became trying to get me into Milan criteria. And the combination of the nivolumab and the various TACE and TARE shrunk the tumor enough that I began to look like a candidate for transplant. And eventually with the nivolumab in combination with, at that point, small things were popping up and they would switch to ablations. And so they would, ablate the small things whack-a-mole. To try to, right.
Yeah.
Whack-a-mole, exactly. So try to, get me to or keep me in Milan criteria. And all that worked. So I'd say from diagnosis of January of 16, transplant was January of 19. So that was a 3-year window of various treatments to get me, where I had to be. The resection was in 17. So that was about a year in. So frankly, a lot of the IO treatments were so successful to get me to the point where surgery became an option. And that was really kind of everyone's first, well, again, the first goal was, keep her comfortable, prolong her life. And then it began, I was responding well. So then it became, well, let's get her to resection. Let's get that thing out of her. And that worked quite well. And it was a significant resection. There was some cells left on the margin, so I was radiated, I believe, 30 times with Xeloda. But again, all of that in combination with, I had a small recurrence, and that's when we started with the ablations to, get me into Milan criteria, and then ultimately get me to transplant.
What was the resection like? Because we had another person on here that had a liver resection, also liver ablations, and they actually had a pretty rough time with the resection, much rougher than I guess the people that I've seen in my practice. But was it better for you? Was it not as bad, I guess?
The resection was tough surgery, tough recovery. And I've had a fair amount of surgeries. I would say the resection was harder than the transplant. I recovered more quickly from the transplant than the resection. Yeah, it's a big surgery. 12-inch incision. You're in ICU initially, similar to the transplant. Lots of drains and tubes and cords. Yeah, that was a tough recovery. I had a lot of pain after that. I think maybe the theory is that I'd had so much abdominal surgery by the time I went to transplant, I didn't have any nerves anymore. Maybe that's why it didn't hurt anymore. I don't know. I don't know. But the resection was a tough surgery. Yeah.
I think that's important, listeners to know, I guess, in making an informed decision. Because I've definitely had people where, it is a big surgery. I'm not trying to minimize it. I've had people tell me that, it's, not that bad with the recovery. But I've also heard people like yourself where it is a bit of it takes a little while to recover from it. And it is a big thing where you're in the ICU afterwards and everything like that. So to just, I guess, so people know what they're getting themselves into. But it is a very valuable option to cut it out if you have that option.
Yeah, no question. It was a good thing at the time. So, I always look at my treatment as kind of a beautiful tapestry, right? I've had so many different things between various surgeries, IO treatments, chemotherapy, that maybe if you pulled one of those strings, the whole tapestry would fall apart. That maybe, as it evolved, I needed each thing, at the time to get me to the next stage. So it is quite a team approach. And I'm very, very lucky that I was at a large cancer center that had a team approach. And that's really the advice that all of us should be giving friends, family, patients. They need to get someplace that has a multidisciplinary approach so that lots of views can be considered. I even had social workers talking to me, so it wasn't just, physicians and palliative care and, all the above.
I completely agree. And it's not, it's not exclusive to those big academic centers, but it's definitely more common there. And that, to your point, if you're a patient that feels like you're kind of talking to someone who's living in the silo, it might be worth getting that second opinion if you're not already, to try and get those outside perspectives, because medicine is so complex and large. It's just not possible as one specialty to really be familiar with all the different options out there.
Yeah, I just found it, for me, again, from a completely different perspective, it was just comforting to me to know that there were 2 or 3 people sitting around a table. It's humbling, really, talking about my scans, and, I can cut it out. Well, I can ablate it and she'll recover faster. Well, maybe it's a systemic treatment and maybe it's a combination. And it really, for me, was a combination. So, different things at the right time.
Do you have other advice that you would tell people in terms of, goes both future patients considering these but also the clinicians taking care of them, that made your experience better, or things to watch out for?
I'd say for the patients, we've touched on some of it, Eric, which is, you've really got to advocate for yourself. And again, that's harder for some people than others, but try to be as informed as you can, ask questions, be prepared, as we talked about, for every appointment. Take a note taker with you if you can, get multiple opinions, look for support groups. I happen to have mixed HCC and cholangio. So I do some work with the Cholangiocarcinoma Foundation. They have a very elaborate program of mentors, and they'll assign a mentor to somebody. I'm not a physician giving advice, but I can help them coach them in what to pack when they go to the hospital, to coach them to try to eat really well, to try to get outside and get some fresh air, all the things they might not want to talk to their doctor about. So getting just somebody else to talk to and maybe they're not comfortable leaning on their family member, so they can lean on someone, like me. I also tell them to work really hard on their physical and their mental health as much as they can. Try to eat as well as you can. There's special nutrition books depending upon what you're going through. Meet with a nutritionist. Talk to them about what you're eating. It's never too late to, try to get a little bit better diet going, but also physically, get outside, get some fresh air. It's hard to be active during this stuff. And sometimes, you really just have to force yourself, or maybe have a buddy force you to get up and get walking. We had a program at Hopkins called Stepping Out. And I would literally go into the patient's room and get them to try to get up and walk after these big surgeries, because they might tell their doctor no, but they might not tell me no. So I think trying to be, but mentally as well, journaling, meditating. I think I live a little bit more in the moment now, as you can imagine. But and I joke and said I haven't dyed my hair pink yet, but I do meditate every day. And I think trying to take care of yourself physically and mentally it sounds basic, but it's really, really important. To the physicians, we talked about the multi-D approach. I really am appreciative when doctors help me minimize my scanxiety, right? And so they'll do that.
I like
right?
scanxiety. I've not heard that before.
Yeah, I wish I had coined the phrase, but I lifted it. But, I've noticed that some of them will try to schedule my appointment almost the same day as my scan. I think, wait, you're optimistic you're going to get it back today, right? Or the late one day, or just to minimize that wait period and that anxiety over all that. But really, we've already dwelled on this. But an honest assessment of their prognosis is really the key for me.
And I'm also interested in what you were saying earlier in that about the educating yourself. Is sometimes I think it's hard. It's almost like you're drowning in information if you try and look something up medically online. And it's hard sometimes to weigh kind of the good from the bad, the truthful from the not so truthful and stuff. How did you navigate, or did you find here's a website that was really good for helping me? I mean, you mentioned Hopkins has some good information.
Yeah, that's tricky. You can't Google HCC and a recurrence, or you'll think you've got a week to live. I mean, it's and you can't do that. I mean, you can, but it's not helpful. Wasn't helpful to me. I tried to focus on professional websites. I tried to, things from National Cancer Institute. I mean, there are resources that are really very good and very helpful. But I think, for example, for a cholangio patient, if you can start with the Cholangiocarcinoma Foundation, they have a lot of really good resource, and a mentor can put you in the right direction. They can open up doors for clinical trials. So I think if you can start with people that are experiencing it or have experienced it, that'll give you a big head start, rather than Googling, WebMD for that. That wasn't helpful to me. In fact, that was pretty scary.
Yeah. Well, I just have a lot of patients I talk to that, because I completely agree. I tell everyone, you have to be an advocate for yourself. The more people you have in the room and everything. And a lot of people will apologize that they look stuff up to me, which I'm always like, no, it's your body, your life. You should be looking stuff up and stuff. But they also have a lot of those experience where they're like, oh, I searched for renal cell carcinoma or HCC or something, and I heard that I have 2 weeks to live, and that it really freaked me out and everything. So that's why I think it's a hard balance, because you want to be an advocate, inform yourself with information, but then there's all this other stuff on there. So
much more an art form than a science. And I guess maybe patients don't know that going in. I certainly know that now, that, if my treatment plan was a tapestry, right, or some art form, then really my recovery and outcome was the art form of your profession. In other words, practicing your craft technically, but also that resonating knowledge that comes from your experience, your judgment, taking risks, your compassion, and that all, I can be informed, but I have to be informed with the right information and from the right people to have it all come together.
Yeah. I mean, it goes back to what you said before about being a person, not a liver. Is, yes, you have a type of cancer that other people have, but your experience with it is going to be different, informed by all this very important context. The plug that I was going to make was just that the nonprofit that I'm part of, that also was putting together this podcast series, has information for patients as well. It's been vetted by patient interest groups and everything else. It's DII.org.
No, I've been on it, and it's super informative. I love the graphics, easy to understand, answers lots of questions about what the procedures are. I wish I had known about it in 2016, but...
Oh, we need to do better advertising it, so we can put it in the show notes for people that are interested.
It's a serious plug. In fact, I've asked the team at Cholangio to make sure that they're linked to it, because I'm not sure that a lot of groups. I'm working with another small group to raise awareness for patients in interventional oncology, and I just think there's not enough good things we can say about these kind of procedures that are easier to recover from, that have great success rates, that are just part of the tapestry for me.
Yeah. Oh yeah. I mean, that's one hope of this little podcast series as well, is that maybe by hearing different people's stories with this, it gets things out there that maybe people haven't looked up before or heard of before for whatever reason. And then maybe they'll consider it or ask their physician about it before they ask about their prognosis as well at the end of the conversation.
Right.
So
right. Absolutely.
Are there other things that you think that we should talk about in your journey? I guess we should talk about the end of the journey, which is that you had the transplant. Where are you now? Did you ever have any recurrence afterwards, or is now you're just in blue waters?
I had a small recurrence, maybe, let's think about 3 or 4 years after the transplant. Very, very small. The initial biopsy said it was negative because it was so small. It grew to about 2 centimeters. I had a recent resection in June, but I think they feel that it was a stray cell, and they're watching me closely, obviously, but I'm going through, now they're using ctDNA. The technology is so cool now, right? So they know exactly what mutations my mass consisted of. And so now they can track it and trace it. And I'm using Natera, and my last ctDNA was negative. So apparently now there's nothing floating around in me, but time will tell. And any of us don't know what's happening, but I'm being surveilled pretty closely, which is good. So yeah, right now, blue skies.
That's fantastic. And we're happy to have you here. So
thank you. Yeah, it's been 9 years since my diagnosis. So I'm pretty lucky, very, very lucky.
Well, is there anything else, like parting comments or advice, other things that you think we should talk about?
No, I mean, I think, it is hard to get second opinions. It is hard to go down this path, but there are a lot of resources to help people. There actually are resources to help fund even transportation for second opinions. A lot of them can be done virtually now. So I just think I encourage all the folks that I mentor to just push hard, try, ask questions, and just no question's a dumb question. Look for mentors, look for people that can help you that have been through it before, because you're not alone.
And that is wonderful, sage advice. So,
good. Well, thank you.
Well, thank you. Thank you for coming on the podcast. With that, I think we can wrap up. Thank you so much again for sharing your story with us. I think that it highlights, so many important things between advocating for yourself and, making sure that different ways you can reach out to do this research, but then have all these different options and really being part of that tapestry and having that multidisciplinary team so that you can have that uniquely positive tapestry, hopefully, and have someone like yourself with us here 9 years later. So thanks again. And
thank you
everyone for tuning into the BackTable podcast, and we'll see you next time.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dawn,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening.